Evening, everyone. Welcome to My IVF Fences and the European Fertility Society. We are back with Dr. Garcia, as you can see. Hello, Dr. Garcia. Welcome back
Hello,
to My IVF
Caroline.
Fences. Welcome to our webinar session. It's great to have you back. It's been a while, but we are happy to have you. Everyone, let us know if you can hear us loud and clear. I believe so, but of course, it's always good if you could confirm it. And we are always curious about whether you are coming here from UK or some other parts of Europe or perhaps some other parts of US or Australia. I know that many times you come from different parts of the world. We are always happy to have you here. Yes, I can see. So thank you so much. From Congo. Okay, thank you so much. Good to see you here as well. And as you know, we will talk about carrier genetic testing, screenings, of course. We have our expert who will introduce this topic and will explain briefly what is all about. But I know that most of you are here for the Q&A session, and we will be able to answer some of your questions, but we will start with the presentation. During the presentation, you can ask your questions, type those in the chat, so that Dr. Garcia can simply answer them for you. And let me just say that Dr. Garcia is the medical director of El Ángel, which is located in Malaga. And he's been with us before. This is not his first webinar with us. I'm glad to have you back, as I've mentioned. And I think that we can start with our topic. Dr. Garcia, are you ready?
Ready when you are.
Brilliant. Thank you so much. Remember, it's recorded, and of course, everything is anonymous, so I can only encourage you to type the questions in the chat, and we will definitely answer them for you right after the presentation. And the presentation is right here. Let me just go to the very beginning of it, and I think we can start. Ready?
Ready? Okay.
Let's go for it. Thank you.
So good afternoon or good evening, everybody. And well, today we have to present this carrier genetic testing. And every time that we talk about genetics, sometimes it's a bit tough to understand this. I will try to be not very long in this, quite short, and then to explain things as clear as possible. So here, the carrier genetic testing, the key word here is the carrier. And then I need to explain something about some confusing concepts. When we know that the baby has been born with a defect, with a problem, then we mistake different things: chromosomal problems, genetic problems, and congenital problems. Chromosomal problems is, you know, that all of us has 23 pairs, 46 chromosomes. So sometimes the baby comes with one chromosome more than 47 instead of 46, or one less. For example, Down syndrome, which is a baby who is coming with 3 chromosomes in the pair 21. So it's the whole chromosome, which is double reproduced, or there is one less than it should be. Then we have the congenital problems, where they are not genetic things or chromosomal things. It's just, for example, the cleft palate or cleft lip, where there is a defect during the growth of the baby inside the uterus, but without the backup of all the reason of having chromosomal or genetic things. And then we have the genetic problems. And the genetic problems means that there is, let's call it's not a protein, but it's a molecular thing inside one of the chromosomes which causes the problem. For example, cystic fibrosis. A person with cystic fibrosis has all 46 chromosomes, but then there is one of the chromosomes has that very small defect, molecular defect, that makes appear this disease. So we have to concentrate on these genetic problems. Here we see a karyotype, the chromosomes, with the 23 pairs of chromosomes. That is where I said that in number 21, we have the well-known Down syndrome, when instead of having 2 of these chromosomes, the baby comes with 3 chromosomes. But Let's go to this other thing. Then let's see this. Here, I don't know if we can see that very well, but when we talk about genetics problems, then we may come across with three situations. Dominant diseases means when the disease is always present. I mean, we have a couple, and the husband knows that he has a disease, and the woman, the wife, is healthy. So 50% of the children will have the problem, and 50% of the children will be healthy with having had inherited any problems. Then we have the next two are the key problems, what we're going to talk today, because these are quite tricky, because these are recessive diseases. Means that, and I'm going to explain that to you as I explain to my patients, I may have received a bad gene from my mother regarding cystic fibrosis, for example, but a good gene from my father. So I'm a carrier. I'm going to be healthy all my life, all right? But I'm carrying one gene which is has the disease, but I'm not. I don't present the cystic fibrosis because I have another one which is a good one and cover the bad one. But then now I meet my wife, and then bad luck, she's coming with the same problem, and we don't know because both of us are healthy. So we may give to our children the two good genes, healthy baby, one good one with a bad one, healthy baby but being a carrier, as we are in this example, or a 25% where I give the bad one and my wife the bad one, and then we have a baby with cystic fibrosis. So that explains how, let's talk about cystic fibrosis or metabolic problem or problem related to bones or mobility or metabolic, as I said, or anemias, etc. Where a couple may have 4 babies and 3 are healthy and 1 has the disease. And it's because of that, because that one has received the half bad one of the father and the half bad from the mother. And then the X-linked recessive diseases. That the tricky things here is that women are carriers and men suffers the disease, because that is molecular problem that we said is set in the X chromosomes. You know that a woman has 46 chromosomes, 2X, a pair with 2X chromosomes, while the man has X and Y. So a woman may be a carrier, for example, of hemophilia, that disease that if you have a little accident, you start bleeding and bleeding and bleeding, and we can't stop that bleeding, right? But women has one X healthy one and one X chromosome with the disease, but because they've got a good one good one, they don't present the disease. But now that woman with a carrier is going to give maybe the bad one to her child, and then the husband gives the Y chromosome. So that X chromosome with the gene affected is alone. They don't have another X1 to compensate, and then that's why the hemophilia, this disease, is carried by women and suffered by men. Okay, so these two are those where the panels are important, because nobody knows that we are carrier. It said that normally 80% of population may carry one of those 1,000. We estimate that there is about 1,300 chromosome genetic problems like that, and it's normal to be carrier of something. So here the problem is to meet our other partner, woman or man, that is carrying the same thing as us. So there is where we recommend the panels. So that is what is the genetic carrier screening. But it's to identify that high risk people. And then we are going, as we're going to see in a minute, we design some panels. But before that, and before show you what sort of panel we have, then the genetic is important because, look, we don't need to read all of these things. But as I said in the third point, there are 1,300 conditions with recessives and X-linked inherited diseases, right? So it's quite a lot. 3 of each 1,000 newborns are affected by these conditions. And 2/3 of every 100 couples, we will see that in more details in the future, are of high genetic risk. Means that it's not sure the couples who are at risk and they don't know of having one of those 1,300 diseases that may happen. Okay, so let's see if I can go down here. I don't know how to work with this, sorry. Okay. Right.
Okay.
Yeah. Okay. Yeah. Here is what I want to show now. It's okay. Yeah, that's right. So look, one with this problem of genetic being a carrier, they have 1 in 300, approximately 1 in 300 pregnancies. The baby comes with one of these genetic diseases. While we're very worried about the Down syndrome, and it's 1 in 800 pregnancies, of course, it increases as the age of the woman increases, all right? Or, for example, open neural tubal defect, spina bifida, for example, is 1 in 1,000. So I think that we don't know how important. Of course, we are not talking about one only disease, but a group of diseases. But the probability of having a baby with one of those is much higher than Down syndrome or spina bifida or cystic fibrosis, for example, which is one of those diseases that we are mentioning today. Okay, so then we have to design a panel because we say, okay, there are 1,300 diseases. If I want to check that before getting married or before having a baby, are we gonna do a panel of more than 1,000 diseases? No, we have to select. And then every international society has its guidelines to recommend which ones and what number it should be convenient. Then, more or less, we have to select groups of panels where these diseases that we're going to check should be severe diseases, should be universal. I mean, not to be just concentrated that disease in one particular area of the world, as it happened with some ethnical problems, but being universal if possible, and easily identify the symptoms, and of course with no treatment available, because if we talk about a disease that can be given any treatment and the baby is fine, that is we assume that is not a big problem, as if there is no treatment at all, right? So I always say to my patients, then on TV and in the media, we said that more money should be invested in these rare diseases, the recessive one, probably because once the baby is affected, it's going to be very difficult to, I mean, nowadays there is no method to recover that. But more money should be invested probably in the prevention, as is what we are talking today. So we offer our patients 2 panels. The basic panel with 38 diseases or 38 genes, 15 or 16 genes, which are those that the husband and the woman and the man should carry, and the X-linked, as we said, those who are hidden just in women, and the woman by herself may give a baby with a problem. And then the extended panel, where we study 552 genes. So what does the difference in the my patients normally choose the first one, the basic one, because in these diseases are concentrated those with the higher prevalence in the population, means that those who are more common. So, and of course, it's more probable that one woman meets a man with the same gene defect as if the disease is more rare, it's not so frequent, that is more difficult that those patients meet together with the same problem. So this is one of our panel. This is the basic one, and there are many diseases. We're not going to read them all. The most typical and famous are the beta thalassemia, anemia falciforme, which are types of anemia, the Tay-Sachs, which is quite common for in some part of the world. We said it should be universal, but it's quite common, and very severe one as a muscular atrophia, spinal atrophia, or the cystic fibrosis, which is the third one, which, as you can see here on the right, 1 out of 28 people in the world is a carrier. 1 every 28. So the possibility of finding a woman, in case, because I am a man, I'm always thinking about that, or a woman finding a man being a carrier as well, is quite high. And the possibility of that couple to give birth to a baby with cystic fibrosis is at 25%. So it's quite serious, the problem, right? And then now we have, these are the list of X-linked diseases. So we will see our donors, for example, women and men as well, has these sort of panels. I'm talking about egg donation in women, of course, egg donation, and our women, our donors, have these panels done before donate the eggs, all right? We will see something now. So when should we done this? Of course, before we start our reproduction cycle, we have to offer that to the patients. And before, as a plan, I mean, I always say to my patients that I have to explain that to them, because we have to cover our back. I mean, that if they have a baby at home and that baby comes with a problem, well, I'm not responsible for that. But if they come to a reproduction unit and then they have a baby again with one of these diseases, cystic fibrosis, for example, he or she could tell me, why didn't you tell me that there were a panel and I would have done something? Well, so that we have to inform, and then they will decide. How we do that? Normally, there are two ways of doing that, because women have these X-linked diseases, because women are particular in the way that they have two X chromosomes, as we have said, they go normally first. So women first, they do the panel. If that woman in particular do the basic panel, for example, and she doesn't have any mutation, any gene with defect, then we ignore the husband or the couple, because as she doesn't have any, it doesn't matter if the man has 1 or 2 or 3 mutations, because we need the same one on both sides. This takes more time. It's cheaper, more economical, or the couples say, well, we are gonna do this at the same time. So we, instead of waiting 3 weeks or 1 month, 2 months, I mean, because if the woman does it first, and then she has something, the husband or the man has to repeat it. So we have to wait another 3 or 4 weeks. If they do it at the same time, we are shortening the time. Okay, the time is short. Right. So what is the genetic matching? It's just what I have said now, but we apply these to donors. I mean, is to check that in the couple, the man and the woman don't have the same genetic problem, and consequently the baby is not coming with, it's impossible that baby, future babies are going to come with one of these diseases. So the woman has done the genetic panel, and she's a carrier of, as we said, again, well, alpha thalassemia, And then the man has done the panel as well, and then we have seen that he is not a carrier of alpha thalassemia, but another different thing. Let's say Tay-Sachs. Okay, they are carriers of different things, so we have done the genetic matching, and we know that the baby, it's impossible. The baby may come with other problems. I mean, I always say that we are not telling you that your baby is going to be Superman or Superwoman. No, but this disease is a study. The baby is not going to have these diseases. All right, he may come. Well, there are other ways to check that the baby is coming well with the high resolution scan, or checking the chromosomes with the prenatal test to check the chromosomes in maternal blood, etc. But these genetic diseases cannot be checked once the woman is pregnant. That is one of the mistakes. Well, I can do that once I'm pregnant. No, once you are pregnant, we cannot study these panels. It has to be before that. You can do an ultrasound scan to see congenital defect, that the lip is closed, that the heart is on the right, is on the left, not on the right, etc. Or Down syndrome is a chromosomal problem, but not these genetic things. Okay, so let's go ahead. So, well, this is just for doctors. If it's what I told you a minute ago. I mean, if there is a pathogenic mutation, then we study the male. If the male no mutation, then low risk. If she has a problem and the male has a mutation, then what do we do? I mean, what are we going to do if both of them, the couple, has the same problem, are carrier, they are healthy again, but they carry the same thing? Well, we may do IVF with biopsy of the embryos and see which one it's coming with the disease, what embryo has inherited both bad genes from the mother and the father, or in other circumstances, they may choose to change the gamete, I mean, to change egg donation or sperm donation. Okay, so let's go ahead as well now. And so this is the study donor and patient. So as we said, all our donors have this basic panel done. So as a result, if the donor has a pathogenic variant of one gene and the male of that couple doesn't have that one, doesn't have the same mutation, okay, they are compatible because they are not going to have, that couple will not have a problem. The baby will be healthy, and that donor may give these eggs to that couple. Another different circumstances, well, where the donor has this pathogenic variant and the husband, the male of that couple, has the same problem. In that case, are incompatible after the genetic matching, and then we have to look for another donor. Obviously, we cannot. That donor was very similar to the woman of the couple, physically was excellent, but there was a risk of giving a baby with with a disease of this, because of this mutation, in which the donor and the husband had the same one, and consequently the donor has to be changed. And then what happened if the donor has one of these variation of X-linked, that the donor cannot be used, cannot be a donor, is discarded from the beginning, because it doesn't matter the husband, the male of the other couple. That woman by herself may give a problem, as we said at the beginning, with the hemophilia. She may give one of her X chromosomes with the problem, and if the baby is a baby boy, will have the problem, and the husband has nothing to say, nothing to apport, nothing to give here. So that donor, if they have an X-linked genetic problem, have to be discarded. And of course, when we find one of these things in our donors, we inform them for the future. All right? So you can't be a donor because of this, but it doesn't mean that you cannot be mother in the future. But once you want to get pregnant, you have to go to your GP, etc., and to inform them about this in order to do IVF with genetic biopsies, PGTA or PGTM in this case, because we are looking for one special mutation. Right. So here's a summary, and we finish. More or less, I'm going to read some of these. What are we doing with this? That we are reducing the risk of having a baby with one of these rare diseases that we are not expecting the baby. How many couples, they're healthy in the family, they don't have any problems like that, and suddenly it comes a baby with a big problems, as we said, is very diverse, okay? And it's because of that, because in that family, everybody has been healthy, but a carrier of something, and the bad luck of finding that male or that woman in particular, another person who is carrying as well with the same problem, right? So it reduces the risk of having this, and the reduction goes between 47 and 90% has been reported depending on the series. Then this is a screening method. It's not diagnostic. I mean, when one of you, a couple that is maybe hearing us, is going to have that, we are not going to tell them that they have a problem. I mean, they are ill, that they have a disease. No, they are healthy. It's just a screening saying, okay, be careful because you are healthy, and you are healthy as well, both of you, but you may have this problem. That's why it's a screening method, and the couple then will take the decisions that they think more adequate. We may say here that not all these 1,300 diseases are studied, because there are so many, and many of them are very important. I mean, there are things that with some tablets, some treatments from the beginning may sort it out, or they are very rare, and they're so rare that it's very, very improbable to find that problem happens. So another thing that I tell to my patients is that, of course, they always say, well, doctor, what would you do? Should we do this? Well, I can't tell you that. I mean, that's a decision that you have to take. But it's true that if both of you come from the same town down here in Spain, in Andalusia, for example, both of you are cousins or are relative, it's more probable that that mutation that is going in the family may be present. While if you come from the Congo, for example, and your wife or your husband comes from Argentina, it's more difficult that that problems happen. That's why the interracial couples and to change ourselves and not to be just strict to our zone is quite healthy for the future, for the race, okay, for human being. Then what to do when we have this? When we do the matching, as we said, and if the matching we have the bad luck of both of us, both patients of the couple are carrier, then they have, as we said, two options, or biopsy of the embryos to determine which of the embryos are affected and not to transfer those embryos, or one of them may say, okay, doctor, I'm 41, I have very few eggs, and I'm not going to analyze, it's very expensive, and my chances because are very slim, because also we are doing the biopsy looking at the disease, but not at the chromosomes. I think that my chances, and I'm going to change, and I go for an egg donation, or the husband may say the same thing, say, okay, I don't mind to have a semen bank and to change, as we said, the sperm or the eggs. So that all donors in the group are studied, as we said, we check it, and our panels are compatible with other clinics panels as well. So that's quite important, because if we do something and another clinic do something completely different, then matchings from one to another clinic, it's impossible, and it's more tedious and more expensive for patients. So I hope that you I've been clear explaining this. I didn't want to go into the method or laboratory method to obtain this. I think that is not important for our day clinic, but at least you to know the importance of these panels. That, of course, I always say to my patients as well, well, I'm explaining this in my clinic because I have to, nowadays with this litigation, etc., I have to explain everything. I need consent forms written and signed about everything, but this may become very popular on TV one day because some people who is well known on TV talks about that, and as it has become very popular, the blood of the cord to check to keep stem cells. This may become very popular for the future, and all of us to have some sort of a DNA checkup of our genes and our problems in order to avoid these rare diseases in our offspring. Okay, that's everything. And now, if you want to ask me some questions, I'm willing, if I can, to answer them. Okay.
Thank you so much indeed. And I can assure you there are some questions right here. So people are definitely interested. So thank you so much, everyone, for being already active and asking your questions. This is a tough topic for sure. So I'm glad that you are here and we can discuss it. So let's have a look. Okay, Elle has the first question here. So how often that this happens? This is in regards to your presentation. How often this happens that you need to tell the donor they cannot become a donor after the testing? Because you mentioned this in your presentation.
I don't have numbers. I don't have numbers here.
Okay.
But not, at least, let's say that I may have per year probably manage 30 donors in a year. They may donate several times, and at least twice or three times a year I have to inform that they can't donate. So but this is just something, I don't have the numbers, numbers, because
exactly.
They are asking me how frequent are these X-linked diseases in population. I don't have the number. Okay, but well, I always ask about, I gave the example of the hemophilia, which was very well known, is the SARS of Russia, where women, the Tsarina, we say in Spanish, were the carriers, and the Tsar suffers the diseases. So these are not uncommon. One of the most common one is the X-fragile, which is the X is lacking for a piece of X chromosome, and generation after generation it becomes greater and greater, and then one of the generation has the problem. That is quite often. It happens quite often, and we have to check it above all in those women who have short egg reserve. The ovaries have not a very large number of oocytes where they are young. Is one of the things that we have to check. So they are not uncommon at all.
So, okay, thank you so much. I believe that answers your question. So thank you. And let's have a look. Next question. Is there an option to customize the carrier screening panel based on our personal or family medical history?
Yes, but that is not, yes, I understand, of course. Today, I've seen a couple with this particular problem. In that case, we are not talking about a panel. In that case, this particular patient this morning, she said, okay, I've got a nephew who came with a disease, a problem. And when he was investigated, they did a panel, and then we were informed that we were carried of another different things. By doctor, I don't remember now which one it is. So it has become more important now that it was discovered that her brother and that patient were carried of something, and then I will call our genetic department and say, okay, I've got a woman here who is carrier of this mutation. And then they will study the husband, the male, of that particular mutation. But this is not a panel. It's just selecting the problem that they need. You understand?
Okay.
Even sometimes
Yeah,
we do the basic panel. We do the basic panel, and she's to the woman first, and it seems that she is a carrier of alpha thalassemia. And then instead, the husband to do the whole panel in the genetic lab will study only the alpha thalassemia. Maybe it's more economical because that is the important one. The important thing here is that both of us shouldn't have the same thing.
Right. Okay. That makes sense. Again, thank you so much for making this clear. Okay, so what should patients expect in terms of understanding the results? Are there common misunderstandings or confusions?
No, normally it's quite clear because in the end, we don't come into very tough explanations. It's very simple to say, okay, you've done the panel and you're well, no mutations. Okay, doctor, no more problems. Right. Then, if there is one mutation or two, then you explain, okay, you are not always, I say, don't worry, you will never have this disease, okay? You're just a carrier, okay? No problem. Most of us are carrier of something, all right? This is good. We know now this. Now we're going to study your husband. Providing your husband doesn't have the same thing as you, no problem at all. Okay? So yeah, I think that they always understand, I think, but because they agree with that. I mean, the explanation is quite simple. We don't need to go into, even if it's a rare disease, we even don't need to explain sometimes although it's in the report, it's explained all the symptoms that disease may have in the future if an offspring suffers that, but that is not important for the patient because what they want is the offspring, the children, not to have it. And then they will know that very clear.
Okay, brilliant. Thank you so much. And there is another question here. There are actually two more questions. So if you have more questions, go ahead, type those in. If not, we will be finishing. So this will be the final call for those questions. And I will skip this one and go back to this one later, sorry. I just want to ask this one, is similar to the previous one. So how are the results reported? What should we do if the results are inconclusive or show variants of uncertain significance?
Well, there's a few questions here. First, it's presented saying, well, this particular patient, we have found a mutation in that gene, which is cystic fibrosis, and another one in alpha thalassemia. Okay, she's a carrier of that one. Okay, and they in the lab, in the genetic lab, they say we recommend to check the couple to see to do the matching. Okay, that's as simple as that. And if they normally would present the report and we explain and all these things and sort out the doubts. The other questions were how was presented and the others?
Yeah, so what should we do if the results are inconclusive or show variants of uncertain significance?
I haven't come across with inconclusive, okay? Sometimes I've had that problem with PGTA and embryos with no results, okay, inconclusive results. But here they say it is or it's not. I mean, she's a carrier or is not a carrier, right? So another different thing is inconclusive. How they said it's
uncertain significance.
Uncertain significance. Well, that normally doesn't happen because in the panel they have selected, the genetic people have selected those who are of significance. They are severe, and we know that all these diseases are severe. A different thing is, for example, when a woman, let's put an example, have had a cancer, ovarian cancer. So, okay, let's check the BRCA, the BRCA, and CS. And they don't study only that one, but a group of them. And then they say, okay, you are BRCA, BRCA negative, but you are positive in another one with an uncertain significance. Then you call the telephone, or they call the telephone, the mobile, and call the genetic people, and they will tell you exactly that particular mutation, if it's important or not. Okay, but in this panel, that things cannot happen, because those of uncertain significance they are not included because of that.
Okay, so it's a bit different when as you said, PGTA is a bit different because sometimes we can get this inconclusive, right?
Yeah, in PGTA,
and here it's a bit different. Okay, that makes sense. Again, thank you so much. I believe it was helpful, but of course, if you have any follow-ups, you know what to do. And now we will go for our possibly final question. However, if you have more questions, you know what to do. The question is, so what are the limitations of the screening panel? Any limitations?
At the moment, as far as I know, they tell you that there's a 99% point of certainty, because I didn't explain and go into these lab methods of how they work with that, but normally they study practically the whole gene with all mutations. Okay, and that's why sometimes if the gene is very, very large, they may study the mutations, the most frequent ones, and the less frequent ones may not be studied. But in these basic ones, probably in the extended one, in those that we study 500, that may happen. All right, that the whole gene cannot be studied, and there are mutations which are very rare, and if they are very, very rare, it's more rare that both of them have the same problem. Okay, but the specificity and sensibility is very, very, very high, more than 99%. So the limitations, because now they have a method to study the whole gene, because one gene may have different mutations. I mean, if here there are people who are doing PGTM, I mean, when they study, I want to know that the baby is not coming with this disease, right? Before that, we have to do a study of the couple to see exactly which part of the gene in that family is affected, which mutation, because one cystic fibrosis may have 200 sites with different mutations. I mean, one family may have cystic fibrosis with a mutation number 15 and another one in another place. And we have to be sure which one it is to have the probes ready to check the embryo in the future. So nowadays, we check the whole gene with all mutations present.
Okay. Thank you again. I believe it again was a thorough answer here. So let us know if you would like to ask anything else. There's one more question here. Would issues with genetics be the cause of repeated implantation failure?
Would issues with genetic be the causes of repeated implantation failures? Well, these diseases shouldn't be related to that problem. I mean, I'm going to put the question the other way around. The SROD, precisely, I've got on my table here on my desk something that has been published by the European Fertility Society about implantation failure. What is useful, what is probably useful, and what we shouldn't do anything about it. For example, about immunology, they say it's not recommended to study the killer cells, etc. They say what is useful and what is not, and they don't talk anything about these genetic problems. I mean, there is nowadays they don't say, okay, do the genetic panels because that disease and the other disease is related to implantation failure. No, this is nothing to do one thing. Nowadays, as we know, I cannot tell you that of these 1,300 diseases, there is one that probably, but no, we are talking about a problem of a baby who has been born and has this genetic disease, okay? So the chromosomal things are more involved in miscarrying and implantation failure, okay?
Yes.
That's why the European Society, European Fertility Society, is recommending the PGTA, because to discard that we are transferring embryos with chromosomal problems, but not genetic diseases.
Okay. Thank you. I believe it was again clear. So there's a difference. Remember about it as well. And I think that was our final question. Of course, however, if you have more questions, you can still get in touch directly with the team at Vista Hermosa. I'm sure they will be happy to help you out with any of the questions that you might have. The team is working hard to give you all the opportunities or answer any of your questions, I'm sure. Dr. Garcia, thank you so much for joining. I believe it will be the end of our session today, but it was lovely to have you back. It was a great session. Someone is typing, let's give it a minute. I believe it will be a thank you rather than a question, but yeah, I was right. But of course, remember, we are always here for you. So if there's anything you wish to follow up on, I can always forward this to the team, and I'm sure they will be happy to answer. Any final thoughts before we finish today? Anything you wish to add, Dr. Garcia?
Nothing. Just to thank you for the invitation and pleasure, and I'm willing to help anytime that you demand it. Thank you very much.
Happy to hear that. And as you can see, there is one thank you and someone is typing. So I believe it is another one. So thank you everyone for joining. As you know, we will be back with more sessions, more information. We are always here to help you out in any way we can, of course. And as I also want to add that we will be back on Thursday, 7 p.m. London time. We will be back with another topic with Dr. Alan Thornhill. So thank you so much for joining. Very informative. This is the comment we have just received. I couldn't agree more. So thank you so much, everyone, for joining us. Thank you, Dr. Garcia.
Thank you.
Have a lovely evening, and I hope to see you here back again.
Bye.
Take care.
Thank you.
Good night. Bye.
Good night. Bye.